Hello again, EMT student. My name is Paul Bedell. I'm one of the adjunct faculty at Pima Community College, and today I'll be covering Chapter 20, Immunologic Emergencies. So, as I've said before in past lectures, please take some good notes. That way, when you get to class, that first hour will be going over the Q&As. And again, you taking notes will help us discuss the topics that you have questions on. All right, so EMTs, you guys often going to respond to calls involving allergic reactions. Now, if it's a mild allergic reaction, something seasonal, whatever it may be, don't think most people are going to be calling 911 in that situation. But as that mild allergic reaction becomes more severe, then you may get someone actually calling 911. Allergy-related emergencies may involve acute airway obstruction, where that airway just closes off all of a sudden, kind of in a response when you have something that you may have ingested. Very similar to, of course, a choking emergency, but that is a known reason why your airway is closing. And then even cardiovascular collapse. So again, when we've talked in the past about respiratory system and the cardiovascular system, how they work together, if you have something going on with the respiratory system, that's going to eventually affect the cardiovascular system. So you guys have to be able to treat these life-threatening complications that this patient's going to have. Of course, if they are the ones that are alone, calling 911, and they have some severe allergic reaction, aggravated response that's causing their airway to close off, they're not going to be communicating much either via 911 or to you when you arrive. You guys have to be able to distinguish between the body's usual response, an allergen, and an allergic reaction. So again, if you've ever had allergies, seasonal, food, just minor things, you know what your body does to react to that, and then compare that to an actual anaphylactic type of reaction that would be much more severe. So immunology is the study of the body's immune system and how it responds to that invader into the body. The immune system protects the body from foreign substances and organisms. That's the whole defense mechanism. When a foreign substance invades the body, that body goes into alert. It goes into a response to basically act on that invader. And the body initiates a series of responses to inactivate the invader, right? It wants to respond to it and see what it can do to stop that invasion. An allergic reaction is an exaggerated immune response to any substance. And it doesn't have to be something that you think would be something that you would have an allergic reaction to, but your body will become sensitized to it. And eventually, as it progresses and you get more and more contact with it, your body can show a response. When this does happen, your body does respond. It is not caused directly by the outside stimulus. So again, you ate something, got injected by something or ingested something, or something absorbed through your skin. It's not that chemical or that product that is causing the response. It's what your body is doing to respond to that invader. The release of histamines and leukotrienes to combat that stimulus, both of which contribute to an allergic reaction. So again, your body's natural chemical release to be able to fight off what's invading your body. So given the right person, the right circumstance, almost any substance can become an allergen. First, the person becomes sensitized. As I said a little earlier, exposed for the first time, stung by a bee, ate a peanut, shellfish, whatever it is. Then you would have an immune system responding to it, and your immune system recalls that same type of response. So the next time you ate something, got injected by something, again, same bee sting, peanut, whatever it is, your body's going to recall that and then have a more significant response to combat it. Some patients may not know what caused this reaction. And this is why your investigative questions are going to be so important. You want to find out from oral intake, sure, that's important about what foods they've eaten. Have you eaten these foods before? Changes in laundry detergent, changes just in the environment. Maybe they're new to this particular part of town or the state, whatever it is. So we may have to changes even perfumes, colognes, whatever it may be, okay, that we have to try to investigate and find out those questions and find out what is going on. Was it something that was like environmental? Maybe they got stung by something. injected by, some stinger or something, got bit by something, whatever it may be, a certain plant. Okay, so we got to find out these kind of questions, and that's going to be, of course, pertinent to this patient condition. Recognizing the signs and symptoms, very, very important, and then maintain that high index of suspicion to know that this person can deteriorate while they're in your care. An allergic reaction may be as mild to localized, again, something where you got hit by something, whatever, and it stays in this little area, little wheal or just a swollen area, maybe a little itchy, burning, possibly something where it's systematic and it's across the whole entire body when you get an anaphylactic response. So speaking of anaphylaxis, it's an extreme life-threatening allergic reaction. Okay, this is where it's going to lead into shock eventually. It involves multiple organ systems and can rapidly result in shock and even death if not untreated. So you see that diagram basically from the book. It just talks about when you have some type of stimulus that it invades and enters the body and how your body reacts to that. In fact, when it talks about reaction, it comes to the lungs, respiratory system, the cardiovascular system, what it does to the blood vessels, and even the skin. So we expect the bronchioles to eventually start to, if you're having a reaction, to start to constrict. It's harder to breathe. When it comes to the heart itself, it's going to have to compensate for this. Increased, of course, respiratory rate, increased pulse rate, because again, this invader that is this toxin, this poison, whatever it may be, that's invading the body. The blood vessels will eventually start to dilate. Okay, so if the bronchioles are constricting, blood vessels are dilating, and that same amount of cardiac output is going to start decreasing, trying to pump that blood through those widening blood vessels now. And then the skin's going to show some examples, right? Maybe widespread urticaria, some type of rash across the body, swollen areas, itching, burning, whatever it may be. Your body's going to show these signs and symptoms. You got to recognize that. So 3 common signs of anaphylaxis: urticaria, mentioned that one, which is like a rash. You can kind of see some wales, those swollen, raised areas of the skin, along with redness, itching, of course, burning in these areas. Angioedema, so you get areas that are localized swelling, and it could be this example of a tongue swollen in there, it could be lips, could be just a localized area of the skin that, again, where the substance actually made contact with. Even sounds of wheezing, okay, high-pitched whistling, breathing when it comes on exhalation. So when you're wheezing on exhale, okay, you want to recognize these common signs. There also may be some hypotension due to the vasodilation. Again, the blood vessels increasing in size, that blood pressure starts to drop, again, indicating shock, right? Increased capillary permeability, so it's going to start leaking out of the blood vessels possibly. Gastrointestinal dysfunction. It may be nauseated, vomiting, some abdominal cramping, okay? Recognize these signs. So how about some common allergies? Most common is going to be the food allergies. It accounts for about 30% of the deaths from anaphylaxis in young adults and adolescents. I mentioned earlier about shellfish, nuts. Some people can even go to an allergist and be tested for what exactly they're allergic to. It can take upwards of 30 minutes or more because, again, it has to go through the gastrointestinal system, get into the bloodstream, then start affecting you. So it's going to be a little bit of a slower response because you're ingesting. May not include any signs of skin irritation because, again, it's mostly going into the bloodstream, so it's going to be more of a respiratory or circulatory type of distress. It can be severe and may involve respiratory and cardiovascular system, like I said. So medications, another common allergen, and these are like antibiotics, penicillin. Some people have, certain medications that they've taken before and they had a bad reaction to it. So they'll remember those for the next time they need to get contact with an admitted to a hospital. They'll be able to discuss that with them. Even non-steroidal anti-inflammatory drugs, people have reactions to those as well. If medication is ingested, again, the reaction time can be immediate up to that point of once the ingestion has occurred, and again, can be very severe. Reactions to oral medications may take, again, we've already said that, more than 30 minutes because it has to get to the gastrointestinal tract before it eventually gets into the blood system, and then it starts affecting you. So plants, dust, pollens, other plant materials can cause a rapid and severe allergic reaction. Some examples would be ragweed, ryegrass, maple oak. You can even think of like poison ivy, poison sumac, poison oak, different examples of different plants. And just know these type of plants also in your specific response area. You don't have to know every plant in the United States, of course, or across the whole world, but knowing in your local response area what are some common plants that may be ingested or absorbed in some way through these sap or oils and stuff that you may respond to. Then what about chemicals, makeup, soaps, hair dyes, any change that someone may have done differently that may have an acute response to it, or something they've used for years and years, and again, their body becomes sensitized to it, and all of a sudden now they have a reaction. Latex, particular concern, of course, for healthcare providers. It says up to about 12% become sensitized. So we've got to be aware that most of the material we use in the pre-hospital setting is going to be non-latex material. So that should alleviate the concern for us personally, and of course for the people we care for. And that example could be up to nitroglycerin, which is a latex material. The insect's bites and stings. So when an insect bites and injects the bite with its venom, this is called envenomation. The reaction may be localized, again, specific to that area of that injection site, or again, can be widespread. So approximately about 3% of adults and 1% of kids are allergic to the venom of bees, wasps, and hornets. The allergic reaction to insects, stings, causing at least about 50 deaths per year in the United States. And those, again, which ones have been documented for that cause. About half of these deaths, the victim had never experienced a reaction to prior stings. So the first time it was done. Now, speaking of like bees or hornets, they have that stinging organ from that specific small hollow spine, basically, projecting from the abdominal area. If it's a bee, of course, that stinger will tear off. The barb on the stinger tends to latch on, of course, to the site of the sting, and therefore it eventually gets torn off the abdominal area of that bee, flies away, and eventually dies. They won't have that example on hornets or yellow jackets. They can sting. The venom can be injected again directly into the skin or from whatever location that bee or hornet or yellow jacket stung, of course, another animal, whatever it may be. So mentioned that already about the honeybee having the barbed stinger, and it continues to inject. So once left in the skin, it can continue to inject its venom for up to 20 minutes. This is why it's really key and important to remove that stinger as soon as possible. We'll discuss that in a little bit. Then the ants, some ants, especially the fire ants, strike repeatedly. They continue to bite and bite and bite. And they inject a particularly irritating toxin as would bite at the bedside. So you may see some, again, burning areas, swollen areas, basically looking like a rash, and people may be in pain. So some of the signs and symptoms from an insect sting: sudden pain to the site, localized swelling, even some heat or burning feeling. It could be also widespread due to carrier, which we mentioned earlier, redness, itching, and even that raised area of the skin. So ice can help, of course. We have some cold packs that we can apply in the field. So that might be a helpful tool to use. Just realize when you're using it, this is something you want to do at a superficial level, but again, don't have that ice directly on the skin. Ideally, either some type of gauze or even over a shirt, so we don't make skin contact with the ice, any skin damage. So again, it could be localized manifestations, not very serious in some of these situations. We're more concerned about that widespread response. So speaking of, again, what that widespread response would look like: bronchioles closing up, wheezing audibly on expiration, right? Chest tightness, coughing, shortness of breath, difficulty breathing in some way. They're anxious. I feel like I'm breathing through a small straw, so I'm just really freaking out, think I'm going to die. The gastrointestinal complaints, right? Vomiting, diarrhea. They also may be nauseated, and they may have just some cramping, okay? And then eventually that blood pressure will continue. So respiratory failure can certainly take place. because if these airways are starting to close off, bronchioles are shutting, airway is going to be harder and harder to maintain and keep open, so that breathing will eventually cease. If untreated, anaphylactic reaction can certainly proceed rapidly to death, and more than 2/3 of patients who die of anaphylaxis do so within the first 30 minutes. So rapid treatment and transport is going to be essential. A 30-minute window, of course, it could be dependent, especially if there was something that was ingested or got directly to the bloodstream via some type of injection. So we're responding, we've seen signs of, well, it sounds easy, right? If it was just some kind of plant, some kind of medication they were exposed to, some chemical that was, laundry detergent, whatever it may be. You got to think of more of a larger scale. So if it's a swarm of bees, right? That may not be seen. You may have to have the fire department come in. They may have to do some procedures to make that seem safe. It could also be a large chemical release that's in a warehouse or job setting. Again, you have to get the hazmat team in there. So it could be, again, scene size up sounds pretty easy when it's just someone's home, you're showing up and they're having a severe allergic reaction, but it could also be a large scale mass casualty type of situation. So again, scene safety is very key. The patient's environmental, or the environment that they're in, of course, recent activities, asking these type of questions. Maybe they're in the house right now, but you're discussing with them what was going on. They were outside when this occurred. They got bit by a snake. Wondering, is the snake still here in the house? No, of course, it was outside. Is there a sting, a bite location? If so, where is it? Can we see that? Food allergy. So what was it that they ate? Let's see. How much of it did they eat? How long ago did they eat it? Okay, did they induce vomiting afterwards? And then the new medication. So again, let us see the medication. How many have you taken? Are you current on it? Is this a new, subscription? The scene safety again. Be mindful of other potential causes of this respiratory distress. Right? It could just be they're having the allergic reaction, but how about they're having an asthma attack? Right? We have to do albuterol possible. We got to figure out what's exactly causing this distress. Maybe again, it's more psychogenic. They're having anxiety issues. Traumatic injury can also be present. Following the standard precautions, at a minimum, gloves, eye protection, respiratory protection. Don't be afraid to put on your proper PPE. Very, very important for you, your partner, and of course the patient safety. Consider the need for ALS. Maybe you don't have the ability to administer an auto-injector for epinephrine, and the person themselves being out in the rural area or something like that, or hiking or something, and they didn't bring theirs with them. So ALS provider, they would be able to administer epinephrine. Quickly identifying the threats for any life threats that may be occurring here, from respiratory, cardiovascular. We want to make sure we adapt to that, figure out what's going on, and manage it right away. ABCs, super critical, super important. As they start deteriorating, we may have to step in. Again, with our medication, we might be able to do, at a start, we can do some albuterol with a small volume nebulizer, maybe step it up to an epinephrine auto-injector. Maybe we have to assist the patient with their auto-injector, or we can administer our own. So again, ABC should be reassessed repeatedly when this patient is unstable, every 5 minutes. If they're stable, every 15 is fine. Get a general impression from this person as you first approach. How are they? Are they sitting up, tripod though, into distress, having some trouble breathing? Or is it something obvious and they're just waving at you? I'm over here. Yeah, I got stung by a bee. I'm super allergic and I think I'm going to die. Yet they're making full sentences. They're totally, standing up and waving at you. So maybe it's maybe not such a concern, right? Patients often appear very anxious. Again, ALS backup if needed. And look for any medical identification tags. They don't know that they're allergic to this, so they're not going to have any obvious identification to state that. But if they're unconscious, unresponsive, those identification tags maybe benefit. Maybe that is the reason why they're on the ground. They got stung by a bee, collapsed suddenly, they're not breathing, and they have a bracelet that says they're allergic to bees, possibly. So with the airway and breathing, anaphylaxis can cause the rapid swelling of the upper airway, bronchioles constricting, airway swelling, closing up. You only have a few minutes. Again, it takes us time to get to the scene too. So you're already behind in time. So a matter of minutes to assess the airway and provide life-threatening measures or life-saving measures. Work quickly to determine the severity of the symptoms and then a number of body systems being affected. Is it simply just respiratory? Is that respiratory system collapse suddenly, and it's now affecting the cardiovascular system? You have to figure that out and then manage it appropriately. Quickly assess for increased work of breathing. They're going to tell you this, how labored that breathing is. It's a struggle to breathe. Are you struggling on the inspiration and or expiration? What sounds are you hearing? Are you using muscles to do this, right? Accessory muscles or even retractions in the shoulder blade. The head bobbing, okay, you'll see this in younger adults or children. Tripod position, right? Everybody's going to be in that sitting forward, leaning forward. It doesn't feel good to breathe when I'm laying back, right? Nostrils even flaring, trying to take in as much air as possible. See that in infants. And then the abnormal sounds again that you may hear. So again, listen for those lung sounds. Don't forget the sides and the back, right? Lung sounds all around. So wheezing, that's due to narrowing of the air passages resulting from the contractions, right? The constricting of those muscles around the bronchioles in reaction to that allergen. So very important that when that mucus starts building up, the airways start tightening, it's going to be that attempt to try to push out the allergen. So they're still trying to clear it, the body's reaction to try to clear that toxin or that poison or whatever it is that's causing this reaction, this substance. Breathing diminishes again to a point where they're not going to be breathing at all. Stridor, another sound, harsh, high-pitched sound heard on inspiration. So you may get stridor on inspiration, wheezing on expiration, right? Patients may be fatigued. It's just working so hard to breathe, I'm getting tired from this, right? And eventually I'm going to stop. Assess the patient or position this patient into a comfortable position. So if you're ready to put them on your stretcher at some point, keep that stretcher in a seated position so you don't have to have the patient lie back, become more distressed, and then eventually sit them up. So position appropriately, whatever's comfortable for them. If signs of shock, place the patient, of course, supine, right? They're unconscious, unresponsive. You need to be preparing yourself for CPR possibly. Listening to those lung sounds, up, down, all around that chest area. And do not hesitate to initiate high flow oxygen. It may be difficult when the bronchioles are closing up without appropriate medications to open up and dilate those bronchioles. Oxygen even may become less and less effective because of that. In severe situations, assist using the bag valve mask, right? Positive pressure ventilation, really important with oxygenation. Circulation may be present with signs and symptoms of circulatory distress, though. Hypotension is going to be one big one, right? What is that blood pressure? Is it already, when you first got there, under 100 systolically? They're, behind the 8 ball here, they're already going into shock. So we want to go ahead and aggressively treat for shock and get them to the hospital. Palpate for presence and the quality of the radial pulses. Again, if they're, altered in some way, but they're still with it, you can go ahead and check those distal pulses. Don't be afraid to go right for those carotid, right? When that patient is unconscious and responsive. Skin, how's the skin looking? Was it hot and sweaty because they were outside? Is it cool and clammy already? Are they turning blue, red, flushed? And these are all also could be dependent on the type of toxin that's in the body. And then even delayed cap refill because that body is compensating and trying to shunt or draw blood into the core organs. And then, of course, looking for hypoperfusion because hypoperfusion is basically shock, and then you're going to aggressively manage that. Oxygenation, proper positioning. Don't forget thermal management. Okay, even though it's 110, 120, wherever it may be temperature-wise, the patient may be shivering. Okay, because they're going to that decompensated shock. So thermal management, got to remember that. And then eventually the definitive treatment is going to be for anaphylaxis is going to be that epinephrine autoinjector. If you have the autoinjector in your own kit, by all means, deploy the autoinjector. And we'll discuss that a little bit. If it was something that they had themselves and they just felt like they couldn't do it for themselves, then you may have to assist them with their autoinjector, So again, depending on the situation, you can assist or administer the epinephrine that you guys can. The transport position should be pretty obvious. If this person is not in distress and they're just complaining about this, allergic reaction, but it's nothing severe, you may be able to get some type of a patient refusal letter, right? But if it's more significant, going into shock with anaphylaxis, you bet this is going to be a good transport decision. So always providing that prompt transport for any patient who's having that severe life-threatening allergic reaction. Take along the medications. Whatever the patient medications are, of course, it'd be a great idea to take that gallon-sized Ziploc bag with you, whatever prescribed medications that they have. If the patient does not exhibit severe symptoms, consider continuing the assessment on scene. Maybe you can, again, get a patient refuel. Maybe the patient does want to go to the hospital. So be it. But that's going to be a decision when you guys have a good communication with the patient to decide what's the best option. Figure out what is that chief complaint. Because again, they're having some respiratory problems, cardiovascular situation. So what is the chief complaint right now? What's the history? Had this happen? Has it happened before? Diagnosed with something? Prescribe something because of this? You know, what's the example in comparison to that last time and this time, right? What are the associated signs and symptoms? Speaking of signs and symptoms, the first table in chapter 20 has examples here of the respiratory system, cardiovascular system, the skin will show, and other findings. So it'd be very, very important to look through any of these tables and any of these chapters and get an idea of what you can expect to see. Doesn't mean that a single patient's going to have every single one of these bullet points. Just know that these could be good examples of an allergic reaction. Not forgetting our sample, of course, the signs and symptoms, the allergies, medication, pertinent past medical history, last oral intake, and don't forget the output and the event leading up to it. And the same thing, including your OPQRST and those two investigative questions, right? The onset of it, okay? What's provoking it, good or bad, you know, positive or negative? The quality, in your own words, you know, describing it. Is it staying local or is it radiating somewhere else? Your severity from like 1 to 10, you know, and describing it in your own words, how bad is this? Trying to compare it to something else, right? Then time. Over this time that you said it started, how has it been going over that period of time? Getting better, getting worse? Did you try something, right? Investigative questions. Have you tried something? Did it work? Has it happened before? What did you do last time? Did you go to the hospital last time? You know, did it just go away on its own? You know, think of a couple other questions that you can think of pertinent to this type of patient's condition. And again, if you have done interventions, what was the outcome of those interventions? And if it's happened to you before, what did you do for it last time? How did it get remedied last time? So again, being alert to the statements regarding ingestion of foods that cause this. Have you eaten those foods before? Is this the first time you ate it? How much of it did you eat? Did it induce vomiting? Again, and then and how long ago did you eat it? What did you eat it with? Right? Maybe some type of, you know, if it was alcohol, maybe it was just some other type of fluids and stuff. So what else have you eaten with it? And then what kind of complaints are you having in the tum-tum, right? You get so nauseated? Did you actually do some vomiting? Is there any abdominal cramping with this? Is that abdominal cramping, you know, normal? Like, is it just something that you normally do have abdominal cramping after a large meal, or is it something that's unique and different? So for physical examination, when we're doing our secondary assessment, this includes, again, systematic head-to-toe type of assessment, focusing on areas of concern. We cannot miss the bee stinger. So if there's a bee stinger somewhere on the body, we want to make sure as we're going to a systemic type of assessment, going through the whole entire body, that we focus in on the area of the site of the stinger or bite, whatever it may be, to be able to get that stinger removed appropriately. If unconscious, of course, you're definitely going to remove all the clothing, go through and do a head-to-toe exam, trying to find any, again, other situations or other type of injection sites, bite sites, whatever it may be, signs of allergic reactions, right? Remove the stinger once you find it. We'll talk about stinger removal, of course, in a little bit. But if everything else is there, maybe there's still, you know, some type of a tick attached to the person, you know, you got to remove a tick appropriately. And that would just be making sure you grasp the head of the tick with some tweezers and then be able to have it get removed. So again, there may be some plants still laying on the person that's causing this reaction, so removing the plants off the person. It could be chemicals, you know, wet chemical, dry chemical that's on that person. We have to have hazardous materials teams that will be able to get that chemical removed off the person. So it's stopping the toxin that's causing that reaction. So we want to remove that from the patient. And then look up, again, we talked about medical alert identifications. It's on bracelets, necklaces, maybe it's on their phone even. Okay? Listening for the abnormal breath sounds, wheezing or stridor, And then looking at the skin, of course, all across, systemically across the body, looking for any rashes, red areas, urticaria, swelling, whatever. Of course, with their vital signs, pulse, respiratory rates, we know they're going to be getting high, and eventually those high pulse and respiratory rates will eventually start to bottom out. Blood pressure, again, become hypotensive. Eventually, that's going to be that late sign, deteriorating the shock. Pupillary responses, right? Go in there and check your pupillary responses. What's their oxygen saturation at? Okay, do we need to, again, titrate appropriate oxygen levels, but we gotta know what the baseline is, right, before we start introducing proper oxygenation. Then we've said again with skin, color, temperature, condition, and looking for obvious signs of allergic reactions. Keep up with those monitoring devices, whatever it may be, from the actual oxygen saturation to, of course, glucose monitoring. But whatever it is that you're using, monitor those vitals every 5 to 15 minutes. Monitor the ABCs, again, 5 to 15 minutes. Any interventions, yes, you may have to give a second epinephrine auto-injector possibly. And if you were just doing breathing treatments initially, it wasn't getting so bad where you need to inject an auto-injector, you could do another breathing treatment possibly, right? So always thinking of the interventions and if we need to repeat those. Speaking of repeating, what about reassessment, right? The primary assessment you want to reassess, their chief complaint, of course, all the vitals, your interventions, so constantly monitoring those ABCs, constantly monitoring your vitals, seeing if we need to titrate, kick back a little bit of the oxygen or increase the oxygen levels. But every 5 to 15 minutes, depending on the stable patient or unstable patient, right? If they're unstable, you better check it a lot more often than if they were stable, sitting in the back of the ambulance talking to you, right? We don't have to check them as often. The deterioration of a patient's condition could be rapid and fatal, so always keep your eye on them. Get your face out of that computer type, patient report type device that you're using. Get your face out of there and communicate with the patient. Keep that relationship going with them, building that rapport. And we're talking about anxiety, right? So looking out for that anxiety, their mental status changes. Try to keep them calm, reassure them. Don't lie, but just keep them calm, reassure them, and get to the hospital as quickly as possible, thinking of shock management. Determine the severity of the reactions. Determine, hey, can we just start out with a little simple breathing treatment, or do we step it up right away and go to an auto-injector? Mild reactions, again, some supportive measures, simple oxygenation, position of comfort, and possibly a breathing treatment, right? Until it becomes more severe, we got to step up the oxygenation and give them an auto-injector. Shock management, get them transported to the appropriate facility, making sure during that secondary assessment you're removing a stinger if there was so. If you needed to clean them off or decontaminate them because of a chemical, make sure you do so before you get them back to the ambulance. So again, these are key things you want to keep in mind as you're assessing a specific scenario for the patient. So with the rechecking of interventions, there may need to be some a possibility of a second administration. If I didn't say it already, if they had 2 EpiPens, they administered, self-administered one prior to arrival, you may be able to help them with the second one, right? If they go into another reaction. Those epinephrine auto-injectors are not a cure. So if you get one prescribed to you from a doctor saying, hey, you're allergic to bees, now you get stung and you're having a really bad reaction and you give yourself an auto-injection, it's not like you don't have an allergy to bees anymore, okay? It will help you. It will of course, dilate the bronchioles, constrict the blood vessels, and make things much better, but you can go into that reaction all over again. So keep in mind on the way to the hospital that may be. Good communication and documentation. So when you're, of course, giving a telemetry to the hospital, letting them know what you're showing up with, the type of patient you have, you may be following some standing orders through your department or through Southern Arizona EMS, whatever it is that your department protocols say, that you're following these allergic reaction standing orders. And then if you had any questions that they can ask, of course, letting them know their signs and symptoms, what you've actually done for interventions, and what the outcome was from the patient. Are they getting better or are they getting worse? And then lastly, our emergency medical care, like we've pretty much already discussed earlier, but this is going to be the synopsis of it here. So if the patient appears to be having severe allergic reaction or anaphylaxis, you got to administer your BLS care, right? Everything from proper oxygenation, proper positioning, and of course, getting that auto injector ready to go. If it was something you're going to assist with, or you have the ability with special training required from the hospital that you can administer your epinephrine auto injector and then get them going to the hospital, not delay time on scene. So we haven't said it yet, but the remove the stinger is really important. We don't want to pinch the stinger, right, to try to pull it off. I know it can be done, right? It's not going to be hard to do. But if you do that, that end of the stinger may still have a bulb, full of that toxin. That if you pinch it, you may squeeze the rest of it in there, right? So make sure you're scraping those stingers off. Whatever you have that's rigid enough, just scrape it off from the patient's skin, making sure, of course, we're not damaging the skin. So if you're going to use a knife, be very cautious of that. Just scrape off those stingers. Now, on arms and legs and chest, for the most part across the body, it's not going to be too difficult. But just think about areas of large amounts of hair on the scalp, even. You're going to have to move that hair out of the way somehow to get that stinger straight. Because some people can be stung multiple times, and there could be more than one stinger on their person. So thinking about that, going through and feeling where all those stinger sites are and locating them and getting in there and remove it. So once you have removed the stingers, and again, I know it seems like that is an impaled object. Oh no, we shouldn't be removing that. Those are fine, little splinters, little thorns, little burrs, and stingers, those can be removed. But once you removed it, you technically have a little bit of hole, right, in the skin, that it's okay to get some either irrigation solution, sterile water, kind of flush that area. If you have some way of using some kind of soap and water, of course, that would be good, because we're concerned, of course, about infection later. Now, because of swelling, we got to consider ourselves about removing any jewelry, watches, bracelets, whatever it may be that on that area of swelling. So if it's even on the foot and they have some kind of anklet or something like that, just got to remove these areas where the swelling may actually cause that bracelet or watch or ring to kind of cut off blood flow. So make sure you're removing that. Position the injection site below the heart level, kind of reducing the blood flow. Ice, we mentioned earlier, again, we just don't want to have the ice directly on the skin and possibly cause any tissue damage. Then you can have increments, 10 minutes on, 10 minutes off, if that helps too. Our cold packs don't get extremely cold, I know, but it's still a good idea to take, time on, time off. Be alert to signs of airway swelling, other signs of anaphylaxis. So again, this person may want to go to the hospital. They have an allergy to something. They're speaking to you. They're freaking out. You try a breathing treatment because they're in some type of distress and they're coughing a lot. But as you go to the hospital, constantly talking to them, because you may notice that the airway is getting tighter and tighter. They're starting to make audible noises as they're breathing in and out. So maybe something, and then of course their anxiety levels are increasing. So maybe something we have to introduce an auto injector. Placing the patient in a position of comfort initially, right? But it may be where you have to put them in supine position, laying them in a shock type position, because you may have to actually start CPR even if the case gets that bad and it progressing that worse. Monitor the patient's vitals, again, being prepared to provide further support, like I said, even with CPR. Epinephrine. So what is the point of it? Why are we using epinephrine in the pre-hospital setting? So epinephrine is going to be a sympathetic response. It's a hormone that normally your body produces anyways. And this response is mimicking a sympathetic response, right? A fight or flight response. So we can expect that, of course, boy, when that happens in a fight or flight, I can feel my breathing getting more and more, and my heart rate increases and getting real excited, right? So that's sort of what it's going to mimic. But what it's really doing for blood vessels and bronchioles, the blood vessels, it's going to start the blood vessels to constrict. Where again, prior to you administering this, the blood vessels were dilating, causing hypotension, right? So we're going to get them to constrict and get them smaller in size so we can hopefully increase that blood pressure. And then the same reversing trait when it comes to the bronchioles, right? Bronchioles were getting tighter and tighter. It's harder to breathe, like breathing through a small straw. And I want to be able to dilate those bronchioles so I can take a breath without distress. Increasing cardiac contracticity, and that is going to be basically the cardiac output, right? We want that to increase to be able to perfuse the blood adequately throughout the system. And again, relieving that bronchial spasms. And the hopes is by doing so, you will reverse the effects of anaphylaxis, and you'll see that patient starting to breathe better and coming around and not being in such distress. Again, monitor, 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 because they could deteriorate again quickly. So themselves, the patient themselves will be prescribed one, maybe even 2 EpiPens, depending on the severity of their allergic reaction. And then you guys may be also be able to assist with those, or you can administer the ones that you are provided in your own ELS kits. So again, refer the appropriate protocols, consult medical control, talking with that, your base hospital, finding out what it is that you have the ability to do with the proper training, of course. These are just some examples of certain autoinjectors. I have some here I can just show you real quick. But again, all these kits that they contain, you can get them through either the hospital's pharmacy. You can order them, of course, online, all through the department that you're working with, of course. The adult dosage are 0.3 milligrams of epinephrine. And then when it comes to the pediatric dose, it's going to be basically half that, 0.15 milligrams. If medication has expired, so some of these autoinjectors may be clear, where you can see some kind of window through it to see the clarity of the medication. So, and they also, of course, have expiration dates on them. So if the medication's expired, discolored in some way, do not give that medication. It can have an adverse effect of the patient. Letting medical control know that the patient doesn't have any and we don't have any. So again, ALS would be a prompt choice. The epinephrine can have an effect within about 1 minute, and this depends also on the severity of the reaction, the health of the person, the size of the person, a lot of factors in that, but it can react quite quickly from the epinephrine that you administer. So again, it's the primary way to save a life of someone who's in a severe anaphylactic reaction going into shock. Because epinephrine constricts the blood vessels, it may cause the patient's blood pressure to rise significantly, may cause possibly even some cardiac arrhythmias and stuff. So not too many contraindications for epinephrine, but it is important to understand what the patient's condition is, and does it warrant the need, risk-benefit, the need for an autoinjector if this patient has pre-existing cardiac issues. So some of the side effects, again, high blood pressure, increased pulse rate, even though they had an increased pulse rate earlier, right? That anxiety is still going to get them very excited, and again, you're getting that rush of adrenaline. Cardiac arrhythmias, so their pre-existing conditions could be a contraindication. So again, following up with your base hospital. They can turn almost pale, dizzy, lightheaded, some possible chest pains, causing headache, and then possibly even nausea and vomiting. I know it's a good thing that you're trying to give this to the patient so they can actually start breathing again. Realize there are some side effects and can cause some complications as well. Do not give epinephrine to a patient without the signs and symptoms of obvious anaphylaxis. Okay? If someone's just saying, oh no, I have an allergy to peanuts and I ate a peanut, I think I'm totally going to die. Oh, let's save you time and give you an autoinjector right away. No, that's not the reason why you. That's actually going to cause more complications and cause more harm. And those who, of course, don't meet the criteria for anaphylaxis do not get an autoinjector. So some areas may allow administration of epinephrine by intramuscular injection. With an intramuscular injection of epinephrine, the concentrations can be 1 to 1,000. That's that ratio. So find out what your protocols are about that. So there may be an intramuscular injection up in that deltoid area, but for the most part, or more commonly, when you get the authorization from the hospital and the agency that you're working for, you'll be allowed to do that in the thigh, as we're going to discuss right now. So this style here, in fact, I can show you this without sharing this. It'd be easy to see. Again, so this is an old version of an autoinjector here. So you may not see this out in the field too often with patients, but again, people do keep their medications for long periods of time, right? Simple administration for this one is each one should have some type of a safety feature on them. So this one would simply have a back cap that would allow that spring mechanism to be active now. It's live, it's ready to go, right? So you want to be careful, always making sure that you keep your digits away from that live end, okay? Don't even think that you can put your thumb on that tail end for support. Just too much of a risk. Keep that thumb tucked in with the hand and the fist, and it's simply, if this was a self-administration, of course, It'd be simply on the lateral part of my thigh in between the knee and the hip, but that's pretty much my extension of my arm. So also, another version could be a newer style version, not so cylindrical in shape. Same thing here though, grasping it firmly, again, self-administration, outer thigh. And then the difference from this one is going to be, this one has a sheath and it protects you from the possibility of getting exposure with some blood that may be in on a needle, okay? Both of these style, and even this third one I'll show you, would have about a 10-second hold time. So as you press it against the outer thigh, wait about 10 seconds for that full administration of medication. Otherwise, if you just jam into a thigh and pull it out, there's a risk that you'll waste the medication and you'll spray everywhere. So holding it firmly to the outer thigh, keeping it depressed, hold it in place 10 seconds. After you've done so, rubbing the outer thigh where the site of the injection was, because it's gonna hurt, obviously. So kind of give it a rub-a-dub-dub. And then within about a minute, the person should be relieved, right, from that auto injection. And then one last one I just wanted to show you real quick with the, this is one that is, as far as I know right now, is the only one that the FDA approved here in America. And the difference with this one is, so there are Arizona revised statutes. We've all heard of Good Samaritan. Every state pretty much has some form of Good Samaritan. And this is an Arizona revised statute under Title 36. Has different things that the public and so forth can do without training, just like CPR, AED use, Narcan administration. I believe have been added. Epinephrine auto-injectors can be done without training. Because of that, just like an AED, how they talk to you during administration.
This trainer contains no needle or drug and is for training purposes only.
So we know it's fake.
Do not use this trainer during an allergic emergency.
So now this is what a real one would sound like.
Ready to use, hold red safety guard down and off of this trainer. Please leg it against outer thigh. Then push firmly until you hear a hiss sound. 2, 1. Training complete.
Okay. So the difference with this one and what a real one would be, it does have a reduced time of injection, so it's about 5-second hold time instead of the 10 seconds for the normal auto injectors. So that's a little different. But the voice prompts is just really key because now if someone's in distress, they can't speak and like, oh, no, and they pull this out and they're afraid to self-administer because they know it's going to hurt a needle and it hurts. Someone else at the mall or whatever can grab it and go, what is this? And they can activate it and use it and not have to worry about training and worry about a lawsuit, if you will. So that's just something to think about for those different styles of auto injectors. Again, depending on which one you carry at your agency, you make sure you get training on that specific one. That's all I have for this chapter for chapter 20. And please, again, take the notes with you to class so that way you can discuss them with the instructor for that first hour. Hopefully this was a benefit. And hopefully you enjoyed the little backdrop there. You get 10 billion extra credit points if you can figure out what movie that was from. And again, until next one, we'll see you guys later.